We'll start in another 2 minutes. We are just waiting for everyone to join. Okay, I think we should start now. Uh, a very good evening to one and all present here. Thank you for joining in. So, on this occasion of Republic Day, there would be nothing better than talking about something that has been haunting us for the past 2 years now, as COVID-19. And today we are joined with by Dr. Vasant Nagvekar, who is an infectious disease specialist who has completed his MBBS and MD from Bombay University and has also done his fellowship in infectious diseases. I thank you, sir, for joining in, and we'll start with the questions.
Thanks, Krish, and good evening, everyone. At the outset, thanks Rotary Club of Medicrew for giving me this opportunity. I think today I'm going to specifically speak on the hot topic about Omicron, and at the end, whatever your doubts and queries are, I would like to answer that. So I'll just share my screen. And since I think all of you are medical students,
No, there are some non-medicals also.
okay, doesn't matter, don't worry. So it's an Omicron update, and if you see, there's a movie in 1963, the horror movie, and the Omicron variant which came in 1963. And I think if you can go and Google, you might see this, the Omicron variant. I don't know if someone mentioned this yet. If the virus spreads from country to country, then it's obviously the vaccinated people spreading it, because only they can fly, right? All of you agree with me? And if you see this, the COVID 19 in Africa, from where it started, Omicron variant, which drives the fourth wave. In India, it is the third wave. And this slightly older slide of 6 Jan, which now it's crossed 300 million cumulative global cases across, and Africa is around, say, 9.5 approximately million cases. What about India? India, if you see the red line, red bar, is predominantly, if you see South Africa, more than 95% is the Omicron. Whereas in India, Omicron is around, I would say, 80 to 85%. And there is around 10 to 15 or 15% roughly the Delta wave. The Delta is the second wave which hit India. Alpha is the first wave. Delta is the second wave which hit India, and predominantly around 80 to 85%. And in some regions, especially Rajasthan and all that, 100% is Omicron. I think in Maharashtra it is roughly around 85 to 90% is Omicron. So there is still small amount of Delta, the second wave lingering in India. And thanks to the Christmas and the marriages and the get-togethers and the New Year parties, and Goa was flooded with, there was no space to walk on the beach. Megas will vouch for that, and so that is the reason why it spread through like a fire. And what about Maharashtra? If you see the daily cases in Maharashtra, it had crossed in thousands, and Mumbai, it was peaked around 20, 21,000 around 7th, 8th Jan, and today, in last 2 days, it is around 1800 cases odd. So there's a drastic reduction by 90%. So all of us really struggled for 2 weeks, but now there's a good news that it's rapidly declining. In Mumbai, it's hardly 1800 positive cases, and out of that, many of them are asymptomatic positive. So many of the patients who are tested positive are asymptomatic positive. So that is the good news for Mumbai. That and also I think in the rest of the Maharashtra, but Mumbai was the first one to hit. And so if you see Chennai, Delhi, Nagpur, then Calcutta, they are going to follow Mumbai. So they are also going to have the peak. Mumbai had a very rapid peak and a downfall because almost more than 70-80% of the population was infected. Every house was infected with the COVID-19 during the third wave, and that is because of the highly infectious nature of this virus. If you see in Calcutta, Bangalore, if you see the red bar, which is the yellow bar, which is going on. If you see the red bar is Delhi. Mumbai is the blue bar, which is pointing out, is slowly settling down, whereas Bangalore is going at its peak, and so is Delhi. Same thing had happened in the second wave during the Delta wave. When Mumbai was settling down, there was a havoc going on in Delhi because the beds and hospital admissions, there were hardly any. Same thing had happened for Mumbai, but all the other cities follow Mumbai. Same like we are following the West. Mumbai follows the Western country, and the rest of the cities in India follow Mumbai. So there is a question always, I think, for a medical student or for all of you to understand what is quarantine and what is isolation. So isolation means a person who's tested positive is tested positive is goes in is kept in a separate room or stays in a separate room, that is called as isolation. What do you mean by quarantine? Quarantine means those people who have come in contact with the positive patient, and but those are high risk people, high risk contact. Now there is something called as high risk contact. So what do you mean by high risk contact? By the terminology high risk contact, it always happens it at home, or it happens in canteens, or it happens in gatherings, marriages, it happens in the hostels, where everybody stays together without wearing a mask, and like at home, because everybody without no, is without mask, and everybody has food together. So while eating food and all that, we talk to each other, and if one of them is positive, it will spread to others. That is called as high risk contact, and this spread is always when your mask is lowered. So if you just recollect, where would your mask be lowered? Your mask is lowered only in eating places, that is in canteens, at home while having food, or gatherings, marriages, and that's the reason why wherever your mask are lowered, that is called as a high risk contact. And all those people who have come in contact with a positive person is to be quarantined. But practically this quarantine was very much was there in the first and second wave and third wave, the quarantine, because what was happening, by the time one person is positive, within 48 72 hours the whole of the family was getting positive, because the highly infectious nature of the Omicron, and also because of the shorter incubation period. Now, the incubation period, I'll come to that in later subsequently. What was the incubation period? So, these are all the genes, the spike protein, the nucleocapsid protein, the envelope, the membrane protein, the S gene. So, we talk about all these ORF1A, ORF1B, the S gene, and the E gene, and the N gene. So, whenever test is performed, I'll come to this in more detail when I talk about the test, how these N gene, S gene, E gene is important to diagnose whether the patient has got Omicron or whether he's got a Delta. So that we'll talk in subsequently when we talk. If you see this slide, this is not only US, but similar thing had happened for India also. Only thing is India started early May, June. If you see, it was to begin with, it was alpha, then there was some variants of concern, which were the beta and the mu, and then it was the delta which took over completely, and subsequently in the last early part of December, or I would say 24th or 20th of the December, the Omicron started in South Africa, and then this January 2022 has been completely replaced. The Omicron has completely replaced the Delta. The Omicron is B11529, identified in southern Africa approximately 20th of November, and it spread like a fire across the world, and immediately within a short time, within 2 to 4 weeks also, it started settling down. Delta was B1617.2, which emerged in India late 2020 and spread across the world. So Delta, there was a Delta Plus also, which was there in India during the second wave. Now, what is a variant? When an infected human cell assembles new coronavirus, it occasionally makes tiny copying errors called as mutations. Scientists can track mutations as they are passed down during a lineage, a branch of the coronavirus family. A group of coronavirus that share the same inherited set of distinctive mutation is called as a variant. Like, you will have, whenever you have a RNA or a DNA sequencing, you will have certain proteins which are replaced by another protein, and that is, or deleted, and that causes a mutation, and that helps us to, not only these mutations help us to not only direct therapy treatment part, but also it helps us to make vaccine. So this is called as genomic sequencing, which is there in the world for the last 10 years. Now, tracking the Omicron and other coronavirus variants. Omicron carries about 50 mutations not seen in combination before, including more than 30 mutations in the gene for the spike protein. And that's why if you see majority of the vaccines, that is the mRNA vaccine, or the that is the Moderna vaccine or Pfizer vaccine or the AstraZeneca vaccine, all of them worked against the spike protein. But this Omicron caused 30 mutations in the gene of the spike protein. And that's why, in spite of taking 2 doses of vaccines of the Pfizer or Moderna or even the AstraZeneca vaccine, it did not protect them from getting the Omicron. And similarly, even the saddest part is that also those people who had suffered during the first and the second wave, okay, did not get protection against the Omicron because of the 30 mutations in the gene of the spike protein which this coronavirus had. Luckily for all of us, this virus has been of a very milder nature, and that is a good part of it. The, the duration of illness or symptoms is very mild, and quickly in 48 72 hours, majority of the people without any medications also recover quickly. If you see, Omicron spike protein has several mutations that are found in other variants of concern and that are thought to make the virus more infectious, including the D614G and 501Y and the K4179. These are the mutations. This is more for, sorry, for the medical students because I think they need to understand this better. Now, coming to the COVID-19 variant B11529 variant Omicron. The B11529 variant has this very unusual constellation of mutations with more than 30 mutations in the spike protein itself alone on the ACE2 receptor, the protein that helps to create an entry point for the coronavirus to infect human cells. The new variant has 10 mutations. In comparison, the beta variant has 3 and the delta variant has 2. So these specimens were various we came to know when the specimens were collected from South Africa and Hong Kong. So where did this Omicron originate? Coming to the story, the variant is believed to have originated in South Africa roughly on November 24th, according to WHO, and brought on a fresh surge of infections. The WHO said that the first known confirmed B11529 infection was from a specimen collected on November 9th. Omicron has been seen in travelers to Belgium, Hong Kong, Israel, and as I said, this is spread more by the people who are vaccinated. And why? Because only vaccinated people are allowed to fly. So this was carried across the world by our own people who are vaccinated. Now coming to the new variant, this variant did surprise us. It has a big jump in evolution, many more mutations than we expected, especially after a very severe third wave of Delta. For us in India, it was second or third wave, whatever you want to say. The B11529 variant has a very unusual constant mutation with more than 30 mutations in the spike protein, as we discussed. These were the the VOC, that is variant of concern, that is alpha B117. Then we had beta, that is B1351, which again reported from South Africa. The gamma, which was reported in Brazil in a small number of cases. The delta B1617.2, which was reported in India, and really it created havoc in India, and then it spread across the world in US and all that, where there was high morbidity and mortality. And then comes the third or fourth wave, whatever, say for the world it would be the fourth wave, India it would be the third wave. The B11529 first reported in South Africa in November 2021, and India it started in December. And these are the various spike mutations of interest. I mean, more of theoretical value, but practically it doesn't matter. If you see the new, that is the spread. If you see delta, it almost took some time, over 50, but for this Omicron to reach the peak, it hardly took a couple of weeks, and that exactly we have seen in Mumbai and across India, that it just takes a week or two. You'll be surprised by day 3 there are 1,000 cases, by day 7 there'll be 10,000 cases. So that is the way how it is multiplying fast. Now there's something called as variant of interest. The possible attributes of variants of interest are specific genetic markers that predicted to affect transmission, diagnostics, therapeutics, or immune escape. Evidence that it is caused of an increased proportion of cases or unique outbreak clusters. It is limited prevalence and currently designated variants of interest. That is, those were very small number, that is lambda and mu. Then comes the variants of concern, the possible attributes of variants of concern. In addition to the possible attributes of variants of interest, there is evidence of increased transmissibility, more severe disease, significant reduction in the neutralization by antibodies, and reduced effectiveness of treatment or vaccine and diagnostic detection failure, which has happened with the Omicron. The Omicron variants of SARS-CoV-2 sublineages. Now, the problem is Omicron is B115291, but it has got sub lineages. That is, it has got BA1, BA2, and BA3. Okay, so you have to remember that there are sub lineages, and this is very important, and it's very important to understand. One is the whole virus is called as B11529. Then there are three sublineages, that is BA1. Please remember this because it's very important for you to understand the treatment part and also the diagnostic part. So there are very important to understand this. So BA11529 is the Omicron. BA B11529 BA1 is one sublineage. Then we have BA2 and we have BA3. So there are three sublineages of the Omicron. 60 mutations compared to the original Wuhan variant, 50 non-synonym mutations, 8 synonym mutations, 2 non-coding mutations. Spike protein, we said there are 30 mutations which are occurred. Now, why it is important? Effects of mutation, because of clinical presentation of the patient, the immune response of the patient, the diagnostic challenges, the therapeutic failures, and the vaccine effectiveness. So the whole question is, once you have mutations, what will be the clinical presentation of these people once they are mutated? So far we have Omicron, we don't know what is going to be the next. So whatever mutations occur, it is whether it's an immune response, whether it's a diagnostic challenges, whether it's a therapeutic failures, or whether it is vaccine effectiveness. So all these questions come into the mind whenever there is a mutation which occurs. And the importance of these are some of the potential consequences of emerging mutants are the ability to spread more quickly in people. There is already evidence that one mutation, that is D614G, confers increased ability to spread more quickly than the wild type. Wild type is the one which is in the community. SARS-CoV-2 in the laboratory 614G variant propagates more quickly in human respiratory epithelial cells, outcompeting the 614D viruses. There is also epidemiologic evidence that 614G variant spreads more quickly than the viruses without that mutation. Ability to cause either milder disease or more severe disease in people, like we know that B117 may be associated with increased death, as well as we know that B617.2, the Delta, had a more severe disease. And the susceptibility to treatment and what about the vaccine effectiveness? So the challenges always evolve once the mutation occurs, whether vaccines will work, the therapeutics will work, how will the diagnostics, whether the diagnostics will work. So the question is Omicron omnious? Omicron is clearly more immune evasive than the prior variant. Yes, this we have proved it because even those people who had two doses or even the booster doses had some protection, and I will come to that in the last part of my talk, that those people who had taken two doses of vaccine or even those who had suffered from COVID-19 did not escape from Omicron. So Omicron, affected people who had vaccine as well as those people who had natural immunity during the first and the second wave. Is Omicron more contagious than Delta? Likely yes, but how much? It is almost 5 to 6 times more contagious than Delta. Delta was more contagious than Alpha by 2 or 3 times, and this is around 5 to 6 times more than Delta. So that's why the rapid spread which happened in Delta, normally the incubation period in Delta virus was around 3 to 14 days, and average was 5 to 7 days. So, like suppose if I would get Delta positive, then my family members would get positive only after 5 to 7 days. Unlike that, in the Omicron, if I get Omicron, my family members would get symptomatic within 48 to 72 hours. So the incubation period is 1 to 3 days, unlike the Delta, which was average was 5 to 7 days. So that was and another thing is highly infectious as well as the shorter incubation period. And that's why, you will see that one person positive, the whole family getting positive within a span of 48 to 72 hours. Does Omicron cause more mild or severe illness than Delta? This question I'll not answer now. This question I'll answer in my subsequent slides, but I would say that yes, it was a milder. Omicron will prolong the pandemic. You will see that the pandemic, at least the Omicron in Mumbai and other cities, has started crippling. That 90% of the cases, we had peaked in Mumbai to close to 21,000, and now it is less than 2,000. So 90% it is less. So it's, 10% which is prolonging. I hope we don't have a fourth wave. Now, infectivity, the same thing. Omicron was associated with a 5.40-fold higher risk of reinfection compared to Delta. The UK Syrian study of COVID-19 infection in healthcare workers showed that it was 5.4 times more, and prior infection afforded 85 protection against the second, meaning those people who had, second wave. But this Omicron actually really did not protect them from the Omicron. Now coming to that, what are the tests which are available? The real-time PCR which are available is the single gene RT-PCR. You must have seen many people who are if they are symptomatic, and when you do an RT-PCR, it comes negative. Unlike the Delta, which was, if you would have done early within first 48 hours, the RT-PCR always would used to come positive. In Omicron, I would say close to 40% of the cases who have proven Omicron, still the RT-PCR used to come negative. So that's why a single gene RT-PCR test may fail. That means if you just check for S gene or N gene or E gene, you may get a negative test. If you check for N gene, S gene, E gene, and ORF, all four of them, then the chances that it will not miss is very high. So that means the chance of coming positive if the person is symptomatic will be high. S gene dropout, S gene, S gene dropout is very, very important, because when there's S gene dropout, it suggests that that is a Omicron. But again, I'll come to this. There is a caveat in this, and that's why I said it's very important to know about BA1, BA2, and BA3. I'll come to that shortly. Now, because this S gene dropout, whenever you have a test which looks, there was a Thermo Fisher, which is a PCR based test. It detects whether there's a S gene dropout or S gene dropout is not there. So the majority of the tests which we do a PCR test, no, it looks for N gene, it looks for E gene, and it looks for ORF gene. Okay, but Thermo Fisher test, apart from N gene, E gene, and ORF gene, it also looks at S gene. Now, what is the importance of S gene is that if you have a S gene dropout, that means S gene, N gene is positive, E gene is positive, and S is dropped out, negative. That means this is Omicron. But what if N gene is positive, S gene is positive, E gene is positive, then it is most likely to be a non-Omicron. But there is a caveat to that, because in the Omicron sublineages, what I spoke about, BA1, BA2, and BA3, the BA2 does not have a S gene dropout. That means, in spite of being an Omicron, BA2 type of Omicron does not have a S gene dropout. And the saddest part of this is that more than 80 to 90% of the Omicron which is circulating in the community is BA2. Again, I'm saying, again, I'll repeat for all of you. The test which PCR test done, usually majority of the tests which are done, they look at N gene, E gene, or the ORF gene. They don't check for the S gene. Only Thermo Fisher test looks at the S gene. Now, what is the significance of the S gene is that if your S gene is dropped out, it says that this is Omicron. And if S gene is positive, then it says that it is not an Omicron. But the caveat to this is that the Omicron BA2 type, that we have BA1, BA2, BA3, the BA2 type does not have a S gene dropout. That means in spite of being a BA2 Omicron, it does not have a S gene dropout. And so we should not falsely get carried away that S gene dropout is not there. That means it's a non-Omicron and it is Delta. The reason is the BA2 does not have S gene dropout, and 80% of the Omicron which is circulating in India or Mumbai is BA2. So they will not have a S gene dropout, but still it will be a Omicron. Okay. But still, if you have some doubts, I'll be more than happy to clear it later. So there is a kit, made in India test kit. Happy to know that Tata has made a made in India test kit to detect Omicron, because it is almost 100% sensitive and specificity is 99.25%, because it not only tells you about a S gene target, but it tells you about S gene dropout, plus it causes S gene mutation amplification also. So it tells you about the S gene target failure, as well as it tells you about a S gene mutation amplification. So this kit, which is I think available or will be available in a day or two, tells you definitely whether this is a Omicron or not. And there is a lot of importance to know whether this is a Omicron or Delta, because your Omicron, your monoclonal, the cocktail antibody doesn't work, whereas your Delta, you require a cocktail antibody. Delta is more severe than Omicron, whereas Omicron is much milder variety. So I'll tell you once I come to the clinical part. I'll tell you more detail about the Omicron and Delta and how do you differentiate that. Okay. So this is what. So unique dual, that is the S gene target failure with S gene mutation amplification, allows specific direct Omicron detection. That is Omicron specific. That is called as OmiSure. And this will tell you whether the Tata one, which is made by Tata's, Omicron specific, that will tell you whether the patient has definitely got a Omicron or not. And if it amplifies all the SARS-CoV-2 circulating variant, that is RDRP. And so this, then it will say that yes, it could be Delta or Alpha, but most likely a Delta, because we don't have Alpha circulating in. So either it will be Omicron or it could be a Delta. So this OmiSure kit will be clearly able to tell us about the whether it's a Delta or Omicron. The same thing, the twist in the tail, I said, because majority of the virus which is circulating of the Omicron, BA1, BA2, BA3, BA2 is the maximum circulating in India, and BA2 does not have a S gene dropout, which actually S gene dropout tells us about the positive. If you see this BA1, so if you see here, initially in the second week of December, we had BA1 6%, 19%, and BA2 was 9%. Whereas now, if you see BA1 in the second week of Jan, BA1 is 5% and BA2 is almost 98%. Okay, so where it was 3% in December, it has become 98%. That means 98% of the Omicron strain which is circulating is BA2, and that will not have a S gene dropout. And then we'll say, no, this is Delta. But this OmiSure kit will help you to clearly understand that this is a proper Omicron or a Delta. Is it clear? Okay. So now if you see this, yeah. So this is a genomic sequencing done. This was in the initial part. And if you see the lower part, everything is BA2, 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 BA2. Okay. So that is the most common which one. Again, this slide shows that predominantly the circulating virus sublineage is BA2. Now coming to the diagnostics part. A 38-year-old woman with type 2 diabetes mellitus has a telemedicine visit. Had a telemedicine visit with me after learning that a person with whom she had close contact at an indoor wedding 3 days earlier has tested positive. So she is scared and she just calls me, "Hey, doctor, I had gone for a marriage and there I was talking to him, and subsequently I came to know that whatever brother-in-law, friend, whatever, that he's tested positive for COVID, SARS-CoV-2. The woman reports that she tells me that, doctor, I'm completely asymptomatic and I've completed 2 doses of vaccination 9 months ago, but I've still not received a booster vaccination. All that is good. She attended a wedding with her husband, who has also received 2 vaccinations, and her 2 unvaccinated children who are 5 and 8 years of age. Her husband has mild nasal congestion and a cough that evening before the appointment. She had previously purchased rapid diagnostic tests that received emergency use authorization from the FDA, and wonders whether using these tests would be appropriate. That means the antigen test. So she has a consultation with me, and then she has a contact 3 days back, and now she's wants to know quickly, even before when she's asymptomatic, whether she would be tested positive or not. What would be my advice to the patient? Now the thing is, if this person who she had a high risk contact would have been Omicron, then within 3 days she would be have been symptomatic. If that person would have been Delta, then this person would come positive only after 5 to 7 days. So if you see this, the viral antigen would come positive at the onset of the symptoms, and so it will not come before the onset of the symptoms, it will come only on the onset of the symptoms, and it will be remain positive up to 7 to 10 days, and then it usually by 10 or 12 days it becomes negative. Whereas your RT-PCR is positive at least 48 hours prior to the onset of the symptoms. What does that mean? That means suppose if I develop fever because of COVID today, I am actually infectious to others 48 hours before I have developed the fever. Now, there is no way or no tool or no diagnostic test which can tell, not everybody randomly can keep checking for the RT-PCR. So there's no tool or test, or I wouldn't, how would I come to know that 2 days back I was infectious? If I develop fever today, that means in last 48 hours, whomever I have met with a high risk contact, that means high risk contact means both the patient, both the people not wearing the mask, would be at risk of developing COVID because of I have developed fever, and I have tested positive for COVID. Now, the only test which would help this lady is not an antigen test because she's completely asymptomatic. If at all the RT-PCR, but if the RT-PCR is negative, that does not mean that she will not develop symptoms. If it is Delta, she may develop symptoms after 5 to 7 days. So we should tell her that possibly you quarantine yourself for 5 to 7 days. I would suggest that do not do a test now. Do a test if you are symptomatic whenever day 3, day 4, day 5, whenever you are symptomatic, do the viral antigen test or an RT-PCR. If you are not symptomatic by day 5 or day 7, then you can, if you don't have symptoms, test it on day 6. And if you're negative, then the chances that you wouldn't develop COVID is very likely. If you see, antigen is very sensitive test when you have an acute symptoms, okay, in first 48 72 hours, whereas RT-PCR is around 70%, I would say. But antigen is like crossing a coin. It can miss, and it even in negative does not rule out. So positive is antigen test positive is 100% positive. I would say close to 98 99% positive, and you need not have to do an RT-PCR to prove that the antigen test is positive. So you should do an RT-PCR. But if your antigen test is negative and if you are symptomatic, then you should do an RT-PCR. And even if you are classically symptomatic, if your RT-PCR is also negative, then you should do a RT-PCR by gene expert, which is very, very, very highly sensitive. So gene expert for COVID-19 is highly sensitive more than the conventional RT-PCR. So I think antigen test is good. If it is positive, it is 100% positive. If it is negative and if the person has classical symptoms, then they should do an RT-PCR. That is very important. Okay. But if you still have some doubts about your test, antigen test or RT-PCR test or gene export or the antibody test, I'll be happy. Now, antibody, there are two types of antibodies. One is a spike protein antibody and one is a nucleic capsid antibody. A person who has taken a Covishield vaccine will always have spike protein antibody positive. But suppose a person has not suffered COVID in the past and is taken only the vaccine, okay, then he'll have only spike protein antibody positive. But if a person has suffered from COVID-19 and also taken a vaccine, irrespective of whether he's taken a vaccine or not, he will have spike protein and the nucleocapsid antibody positive. So that is very important to understand. A person who suffers COVID develops a spike protein as well as nucleocapsid antibody, while the person who has not suffered but only vaccinated will develop only the spike protein antibody. Okay? That's very important. So now this is the importance of diagnostic performance of a rapid antigen test, which I was talking about. The fluorescent rapid antigen test, the use of most of these effective rapid antigen tests leads to a true positive rate. Sensitivity is 99.1 and 90% and 90 to 90.90% for the samples with cycle threshold value of 30, and can be used also from people who are recovered after 7 days to know whether it is infectious or not. You can do an antigen test because the RT-PCR test can keep coming positive up to almost 30 days or more than that. So to know the infectious, I think because the antigen test comes negative by 10 days or for 12 days. So if you want to know whether you become negative, I think antigen test is good to know the negativity. Similarly, antigen, this paper comes from IDSA, antigen based testing, but not real time PCR chain reaction correlate with severe acute respiratory syndrome. What it says that antigen test is more reliable to say that the infectivity acute. The RT-PCRs can come, a person who is recovered after 2 weeks also sometimes because of the dead virus in the throat. Your RT-PCR can keep coming positive. So antigen test would be good. So what is the conclusion is the correlation between SARS-CoV-2 antigen and SARS-CoV-2 culture positivity represents a significant advancement in determining the risk of potential transmissibility beyond which can be achieved by detection of a SARS-CoV-2 genomic RNA. What this says that the SARS-CoV-2 antigen, if it is positive, it correlates that the virus is alive. Whereas your SARS-CoV-2 RT-PCR, even if it is positive, after 10, 14 days, it does not correlate with the virus culture positivity. Means those sometimes you may have a RT-PCR coming positive at 10, 14, 15 days, and when you culture the virus, it will be negative. And those RT-PCRs come positive because of the dead virus in the throat. Whereas the antigen is more correlating with the acute infectivity or of the live virus. That is what it says. So viral dynamics and duration of PCR positive. Unlike the Delta virus, your RT-PCR used to remain positive up to 10, 14 days and used to correlate and up to 20 days in people who are immunocompromised or people who had severe COVID would used to have RT-PCR positive up to 20 days. But with Omicron, if you see 52% were PCR positive at day 5, 25% were, that means at day 6, that means 75% had become negative, and only 13% were positive on day 7. That means 87% becomes negative by day 7. In an average, they say by day 8 to day 10, majority of the people with Omicron variant become negative by culture, and that is why the isolation period, which was 14 days for Delta, has been reduced to 7 to 10 days for the Omicron. Now coming to the clinical features, if you there are certain, when a patient comes to me at Leelavati or Global Hospital or Reliance Foundation at HN, how do I differentiate clinically whether this is a Delta or a Omicron? Now there are certain clinical features. One is that the incubation period. Like suppose if I get, then my whole family members would come positive within 48, 72 hours. Unlike Delta, which used to take 5 to 7 days. So that is one. So the infectiousness is high and the incubation period is small. That is one thing. Second is loss of smell and taste is a predominant feature of Delta, which was almost unheard in the Omicron. I hardly had any patient who was complain of loss of taste and smell. So that is very, very important. If you see this blue bar is of Delta, whereas the green bar is of the Omicron. Fever was the predominant feature in Delta as well as Omicron. Now I'll tell you, there's a certain, this clinical experience tells me that those people who are younger, that means those who are between 10 and 40 years of age, had very high fever, 103, 104 for first 48 hours. Whereas in Delta, the people who had comorbidities had a higher fever. Unlike in Omicron, the elderly people or people who had comorbid conditions have a mild, slightly lower fever. That's why you will see that your parents, your grandmother, grandfather, they have very milder symptoms of fever. Whereas the younger people will have very high fever for 48 hours. They will have 103, 104. Cough. Cough is a predominant feature of both, but I would say Omicron, though this bar doesn't show, but Omicron cough has been nasty. The only complaint after the fever, people complain is, doctor, please get rid of my cough. Shortness of breath is not a problem at all. Sore throat, my goodness, there are only two problems in three problems I would say in Omicron. One is they will complain of severe headache. They will complain of sore throat so much that they'll have difficulty in swallowing also. They can't even, they'll say something is stuck in my throat, which was not a feature of Delta. And the third thing they will say is that cough. Please, doctor, get me relieved of my cough and of my sore throat. I don't have breathlessness. I'm eating well. I'm otherwise fine. I have no fever. Doctor, please get rid of me of my cough and my sore throat. That is one. Fatigability. Fatigability is a more feature of Delta than Omicron. Omicron quickly get back to their normal. Headache I've seen more in Omicron than Delta, though it has been reported here. This is not the thing. Myalgia has been same in both Omicron and Delta. Another thing is that diarrhea was slightly more common in Omicron, and the CT scan abnormalities were almost unheard of in Omicron, but very few people would have it. But Delta, almost those people who had moderate to severe disease, every CT scan was abnormal. So if you check with the CT scan people, almost every person having Delta virus will have an abnormal. So those people who have a CT scan abnormalities could be Delta and less likely to be Omicron. So these are few features which would differentiate between a Omicron and Delta. Another thing is Delta, 15% hospitalization, whereas in Omicron only 1% or less than that hospitalization. And also the hospitalization in only of people who have comorbid conditions. And also the severity is much, much less in the Omicron compared to the Delta. Now let's see the Omicron. Is Omicron more severe? No. If you see the Omicron, compared to the number of cases, this is from Lancet. This, if you see beta, delta, the number of cases. If you see the people who are admitted were much, much lesser compared to the delta. The oxygen requirement in people with the Omicron were much lower. The severity of symptoms were much lower, and the people who died were much less compared to the delta. Another thing is this is from Kaiser from South California, which says that a symptomatic hospitalization, 53% reduction in the symptomatic hospitalization in the Omicron, 74% reduction in the ICU admissions, and mortality 91% reduction compared to the Delta. So the beds were equally easily available during the Omicron. The ICU beds were easily available, which was unlikely during the Delta. There was a lot of chaos in all the metropolitan cities across India about for the during the Delta wave. So in Omicron, the symptomatic hospitalization is less, ICU admissions are less, and the 91% reduction in the mortality. That is what it says. Again, if you see the Delta, the orange one, the bronchus involvement is much more in Omicron. That's why you have that cough, that is bronchitis. Whereas the lung involvement was much more in the Delta or the original compared to the Omicron. So Omicron, the lung involvement is less, and that's why you will see less of symptoms. Now coming to the clinical outcomes among patients infected with Omicron, if you see the ICU admissions, this is no S gene target failure. That means these are all delta. S gene target failure. That means these are Omicron. So if you see the ICU admissions year 23, year 5, this is just a number. Mechanical ventilation 11, whereas year 0. Death year 14, year 1. So drastically severity much less in the Omicron. That is the S gene target failure. Okay. Now, this was a study, same study, which says that there was hardly any death in people on the ventilator. Now, considerable, what is the speciality of Omicron? The speciality of Omicron is that it does not bother whether people have taken 2 doses of vaccine or the booster. It does not bother whether you have suffered from COVID in the past. And it does not bother about the cocktail antibody, that is Casirivimab and Indivimab, which was available by Roche. It does not bother, it does not help at all to clear the Omicron. The only antibody which will clear the Omicron is I'll come to that, is the new cocktail antibody. But the one which was randomly used, Casirivimab and Indivimab, does not work on Omicron, and that is because of the considerable escape of SARS-CoV-2 Omicron to the antibody neutralization. And coming to the treatment, this is the Casirivimab and the Indivimab which was available, and it does not have any role to play in the Omicron. The only cocktail antibody which is not available in India is the Sotrovimab. But the question is to whom to give this Sotrovimab. I think the Sotrovimab is because 99.5% of the people will get better without any treatment. So who is this 0.5% who will require Sotrovimab? These are highly elderly people with multiple comorbidities or with hematological malignancies or transplant population or people who are on chemotherapy agent, I think they are the one who will require sotrovimab. Otherwise, rest of the people, be assured, within 72 hours, majority of the people would get better. What about role of remdesivir? Remdesivir works on Omicron as well as on Delta, so be assured about this. What about the nirmalatravir paxlovid? Again, this is not available. This is manufactured by Pfizer. It will be shortly available. It works on Delta and it also works on the Omicron also. And there's an 89% reduction in hospitalization by the nirmalatravir paxlovid. Molnupiravir, they say 30% reduction, but majority people get better. Molnupiravir to be never used in younger people and people who are newly married or pregnant ladies or about to get pregnancy, and by accidentally somebody has taken molnupiravir. Those people should not conceive for next 90 days is the guideline what's there. Budesonide works both for delta as well as, but these are all alternative medications. The medications to work is the oral injectable as well as oral antivirus, and the sotrovimab, what is the one which is not available in India. And this graph, if you see there's a casirivimab, you will see a big gap. You will see a big gap here. You will see casirivimab plus indivimab. That is a cocktail antibody which is available in India, which is the monoclonal antibody Regeneron. There's a big gap. But when you see the sotrovimab, you'll see, there's no gap. And that's why they say sotrovimab works on Delta as well as it works on the Omicron. But that is on a very small population. Coming to molnupiravir, Paxlovid, almost 88% reduction in the hospital admission, whereas molnupiravir only 30%. But this comes. Now coming to my last part of my talk about the boosters, the safety and immunogenicity of the 7 COVID-19 vaccines as the third booster. That means all those people who had taken 2 Pfizer doses or 2 Covishield doses were given 7 different types of boosters. But the best one which showed good results were 2 Covishield followed by Pfizer or 2 Pfizers followed by Covishield. Okay, and that is what it says. And what was the effect? What is the reason for, do you really require a booster? If you see here, the vaccine effectiveness over a period of time, the effectiveness drops down to almost 70% or 60% and 40% with the AstraZeneca. But with the booster being given, the protectivity is 93% to 95% with all these 3 vaccines. Okay. So this summary of 10 reported studies for vaccine effectiveness versus symptomatic during Delta wave. This was during the Delta wave, but is there any data for the Omicron? Now this is again the data for the symptomatic against the Delta wave, where they shown that yes, your Delta 2 doses don't work well, whereas vaccinated with 3 doses the effectiveness is much better for Moderna as well as, that is a messenger RNA vaccine, as well as this. Now this is the data for the Omicron. The vaccine effectiveness of 2 versus 3 doses. If you see 2 doses against the Omicron, there's only 57%, this thing. Whereas with booster doses, for the Omicron also, it is with the messenger RNA vaccine, the effectiveness is almost close to 90%. For the Delta, it is, which is 81%, is 94%, and for the Omicron, which is 57%, is 90%. So there is some data which says that the third booster dose in specific population will definitely benefit. So to end my talk, I would say Omicron is less severe. I would say majority of the people get better on their own symptomatic treatment, what is required. Very few elderly, multiple comorbid people would benefit with molnupiravir given early. Omicron is highly infectious than Delta, 5.4 times more infectious than Delta. It has got a shorter incubation period, 1 to 3 days, unlike 5 to 7 days of the Delta. Majority of the people self-recover. Vaccine and prior infection has got no, Omicron doesn't bother whether you vaccinated 2 doses or you had prior infection in the past. Monoclonal antibody does not, that is the casirivimab and indivimab, does not work against the Omicron, whereas sotrovimab is the only one which works against the Omicron. Booster, like my last slide showed, that 2 doses is only, that is the mRNA vaccine. We have studied only for the mRNA vaccine is 50% protective, but if you get a booster, it is around 90% protective. Thank you for your kind attention, and be happy to answer all your questions if required.
Thank you so much, Dr. Nagvekar. This was very enlightening, and I'm sure my viewers have received a lot of information about Omicron. And there are some questions by our viewers themselves, which I have collected and will be asking. So the first question being the biggest one, is this the end game? So while the WHO and the global conditions says that the global conditions are ideal for more variants to emerge, the UK and Sweden have announced an easing of all curbs, and it has been decided to end testing for vaccinated travelers. So what is your take on this?
So I'm not sure whether we should be going away from the mask as of now. That is one thing. Second is, I don't think this is the end of the pandemic because the virus keeps evolving between the humans and the animals to the humans. And unless we have a vaccine which takes care of all the mutation, the protein, the spike protein, all the sites, only then we can say that yes, we should have at least 70-80% protection against all the COVID, spike, all the proteins. Then we can say that yes, that is the end of the pandemic. So till then, I would say we'll have to play safe, keep watch, and enjoy in between honeymoon periods. That is 2 months. What I think we can have a good summer, hopefully April, May, and then maybe we don't know what's for next.
Right. Also, about the guidelines, why are the guidelines for different variants changing? And why did the MOFSW or the CDC change its recommended isolation period? So, what is your take on the guidelines which do not recommend a negative test before leaving isolation?
No, so as I think in my talk, I very clearly said, I showed that the 87% of people were negative by day 7, and majority of them, almost 100% in this Omicron, were negative by day 9, day 10, and that's why it was a faster, quick spread, and quick the viremia was not there longer compared as to the Delta. So only when you study them, then you come to know. So that's why the shortened incubation period and no need of testing, because 87% we know that by day 87 means when you call as herd immunity, we just want 70% or 60% of the people to be infected or vaccinated or protected. So your 87% is good. So that's why the isolation period and no need to test is good enough. Unlike, because the only test which you can do is an antigen test. Otherwise, best is not to test and get back to work with the mask.
So, talking about herd immunity, is it possible that Omicron helps us get closer towards achieving herd immunity?
I think in Mumbai we are almost close to herd immunity, because every house, every building, everybody. I think there's a huge. There was a sudden rise and then sudden fall. And what actually the 20,000 numbers is at the tip of the iceberg. Actually, it must be much more than higher, because there's so many people suffering from the similar illness. And what we see in Leelavati Global and HN is only a small population what comes to us. But the majority of the population, I would say 95% of the population, goes to the family physicians or general practitioners. If you see them, their OPDs were packed. Actually, I come to know that the virus, the things are getting controlled not from the newspapers, but I come to know from the general practitioners, because they tell me that my OPDs are now getting thinner and thinner, and I know that the wave is getting also thinner.
Okay, another question that we have here is that a study conducted by AIMS Delhi stated that 2 out of 5 patients had symptoms even months after COVID 19. So, how big of a healthcare problem do you think this post COVID sequelae is? And what healthcare reforms do you think are required to cater to these patients effectively?
I think the major concern with majority of people with Omicron, since it is affecting the upper respiratory tract, is the sinusitis and the bronchitis. So that's why these people keep on complaining, cough, and they have post-nasal drip going on because of the sinusitis. And I think symptomatic treatment is only required, but if somebody is coughing for 3 weeks, a simple X-ray test is required so that you don't miss out on tuberculosis, which the ICMR says. But a routine CT or testing for TB by sputum and all that is not, I wouldn't recommend. I would say just do a routine X-ray test just to see that you don't miss out on TB of 3 weeks of cough. But there are specific clinical features for TB. You have weight loss, loss of appetite, fever, and night sweats. So if you have four of these absent, that is no fever, no loss of appetite, no loss of weight, and no night sweats, be assured 93% that person doesn't have TB.
Okay, another question is, are there any strains of COVID currently or in the future which can cause more severe disease in South Asians compared to other races?
So I think the wherever the mutant will arise, it will spread across the world because it is spread, as I said, by the vaccinated people, and they are only allowed to fly. So we don't know as of now. Hope for the best, but I think I would say be cautious. But possibly there could be more mutations to occur. Just like and it is we have to stay with the Omicron. We have to stay with the COVID-19 because it's become endemic. I wouldn't say pandemic now. Pandemic has become endemic.
Okay, the last question is, to what extent has the pandemic been used by pharmaceuticals and other medical corporates to make their share of business in an unethical manner?
Yeah, so yeah, I mean, there have been a lot of trials and a lot of investment by the pharmaceutical companies into this COVID. At the same time, we really require them because some of the drugs like Paxlovid, that is Nitrolimab, Ritonavir, the Nirmatrelvir, Ritonavir, or the Sotrovimab and all that, are really life-saving and reduces the hospitalization by 80-90%. So they are also required. So yes, to certain extent, yes, but at the larger extent, they are trying to help the population also by coming up with options for treatment part of the COVID-19.
Okay, I think that's all that we have for now. And I think we'll wrap the session up by asking everyone to put on their cameras so that we can take a few pictures.
We can also open questions to people in the audience right now if they want to ask anything to sir right now. You can raise your hand or put it in the chat if anyone has anything more to ask. Okay, I think.
I think all of you, I hope you understood that as gene target failure because that's very important from the treatment as well as the diagnostic point of view.
So,
I think Janil has a question.
Yeah.
Is Omicron affected by teens or adults also?
Sorry, I didn't.
Omicron affected by teens.
do you want to put your question in the chat so sir can read it if the audio isn't clear?
Yeah.
Omicron is effective in teens. So I think it's a very self-limiting disease. So I think the younger you are, I'm sure that it will be self-limiting and you don't require any treatment. So all the younger people, the teenagers and all of them, even if you get Omicron, be assured you'll be 100% better. You won't require any treatment. It's symptomatic paracetamol. At the most, you all maybe teenagers would get high fever for 24 to 48 hours because you people have got good immunity and so you fight with the virus and so that high fever. Actually, the high fever is protective.
I think there's another question in the chat box, which is, sir, how many more boosters will we need in the near future? And do we have to take one if there's every time there's a new variant?
So every time there's a new variant, you can't take a booster. That's very clear about it. Okay. So maybe you may require a booster once in 6 months or once in a year. That is only time will tell us. This is a new virus. All of us did not know also that we should be taking boosters, but clearly it has shown that last slide which I showed that taking a booster did have protective effect against the Delta as well as the Omicron. But the answer is you every time a new variant come after 2 months, you can't take a booster. So yeah, but you may once in a year would be or once in 2 years a booster may be required if this virus really remains endemic for a longer time.
So I know you mentioned that this variant is quite resistant to people who have been infected by COVID in the past and who have been vaccinated. But do you think that the reason why this variant is so much milder is the rapid vaccination that's been going on since last year, or do you think
that is there? Plus, I think the nature of the virus also, though it has caused so much mutations, but the nature of the virus is also called milder disease compared to the Delta virus. And yes, that will be the reason. But also, those people who are not vaccinated did badly with Omicron compared to people who are vaccinated. So there was a definite protection from the vaccination, whatever you have to say.
Okay, I think there are no more questions. Okay, there's one. How does homeopathy or Ayurveda help dealing with the virus compared to allopathy?
So I have no answer to that, but I respect all the branches of medicine, whether it's homeopathy or Ayurvedic. They have a role to play. They may be better off than our allopathic medications. Also, we don't know. But I have no answer to that. But yes, I respect those branches also.
I think we should end the session here. I request everyone to fill in the form that I've put in the chat box. And that's it for today. Thank you everyone for tuning in, and thank you Dr. Nagvekar for an enlightening session. And I'm sure our viewers have learned a lot from this.
Thanks, and it was a pleasure talking to all of you.
Thank you so much.
Thank you.
Everyone who's still here, please make sure that you fill the form before leaving the meeting.